Welcome back. This is video number 6, case presentation number 1. Male patient, 70 years old, presentation with non-ST elevation myocardial infarction, history of hypertension and previous myectomy due to HOCM 10 years ago. Coronary angiography showed mid-LED myocardial bridge. REO code of view showed mid-LED significant myocardial bridge with normal CX and RCA. Since the flow was TIMI-3 flow, old age patient, previous surgery was done, medical treatment was advised in form of beta blockers, antiplatelets, and calcium channel blockers. The patient's clinical condition improved and was discharged. As we can see in myocardial bridge with intramyocardial course, there is mid-LED milking due to systolic compression with partial or complete decompression during diastole. We will discuss myocardial bridge in HOCM cases regarding prevalence, prognosis, and myocardial bridge correction during myectomy. Regarding the prevalence, studies based on CT studies, the prevalence of myocardial bridge in general population is 3.5 to 25%. It increased in HOCM patients up to 30 to 50%. And in a systemic review and meta-analysis 2023, the prevalence increased from 17.5 up to 36.8 in HOCM patients. The prevalence is also high in specific types as obstructive and apical HOCM. In this case, a 32 years old male patient with no risk factors. The complaint was typical chest pain with T inversions in most lead. Enzymes was normal. Echocardiography showed HOCM. Coronary angiography showed normal coronaries. Is there any suspected myocardial bridge in the LED or diagonal artery? Since there is high prevalence of myocardial bridge with HOCM, presence of typical pain and ECG changes with no induction of tachycardia during angiography with absent confirmative views, CT angiography is needed. CT angiography showed no intramyocardial course of LED. Regarding the prognosis, myocardial bridge adds to the underlying ischemic process. There is more increase in incidence of persistence of systolic compression into diastole and deep myocardial bridges in HOCM patients than general population. Myocardial bridge is an independent risk factor for AF in patients with HOCM, as seen in this 2021 study. And in this 2024 study, a myocardial bridge with severe systolic compression was significantly associated with high extent of fibrosis in patients with obstructive HOCM. It is highly suggested that long-term myocardial ischemia is the main cause of myocardial fibrosis, followed by increase in left atrial and left ventricular and diastolic pressure, followed by increase in incidence of AF. In order to answer the question regarding prognosis in patients with HOCM and myocardial bridge, a 2023 meta-analysis was done, including 10 studies. Myocardial bridge was not associated with more increase in cardiovascular mortality or non-fatal cardiac events, yet associated with more myocardial ischemia. In conclusion, there is potential prognostic implication of myocardial bridge in HOCM patients and should not be ignored, especially in those with hemodynamically significant bridges. The main limitation of this study is the broad range of definitions and parameters for myocardial bridge among the included studies. This prognostic implication was also evident in this 2023 study, which suggested that sudden cardiac death risk scores and presence of myocardial bridge were independent risk factors for fatal ventricular arrhythmias in patients with HOCM. Regarding myocardial bridge correction during myectomy, is there benefit? In this 2021 study on 823 patients who underwent septal myectomy, the patients were divided into 4 groups: non-myocardial bridge, cabbage group, unroofing group, and untreated groups. 3-year follow-up showed that all-cause and cardiovascular death were similar among all groups, yet 3-year cumulative event-free survival of non-fatal myocardial infarction and combined endpoints was significantly lowest in untreated myocardial bridge group. This significant benefit was apparent in the treated group, although there is some sort of bias since the hemodynamically significant myocardial bridges were treated during myectomy. This bias may suggest that there is hidden benefit on survival, not just event-free survival. In this case, why was there no myocardial bridge correction during myectomy operation of HOCM 10 years ago? Myocardial bridge was not evaluated. Should there be routine investigations for myocardial bridge in all HOCM cases? What does guidelines say? Should there be routine preoperative investigations for myocardial bridge in all HOCM cases? How to investigate? No symptoms or signs. The patient was on beta blocker and calcium channel blockers. In 2024 guidelines, cardiac CT angiography is not indicated for routine investigations for myocardial bridge in HOCM cases. Coronary angiography is indicated if there is high risk factors for coronary atherosclerosis and evidence of significant myocardial bridge, without stating how to detect this significant myocardial bridge. The other possibility, it was evaluated by cardiac CT or intraoperatively and left with no correction. What is against or in favor for correction? No guidelines supporting routine correction, yet recent studies support correction if severe myocardial bridge. No functional assessment of severity, yet the included studies was based on depth and length of myocardial bridge and showed more prevalence of ischemia and non-fatal cardiac events. It was not severe, yet left ventricular hypertrophy developed within 10 years, most probably with stoppage of beta blockers and calcium channel blockers. Summary. With the high prevalence of myocardial bridge in cases of HOCM with all types and high possible impact on prognosis if severe myocardial bridge, highly consider routine preoperative search for myocardial bridge. CT is enough to get data regarding depth, location, length, and percentage of compression. Further research is needed among a larger population to explore the prognosis post-myectomy, plus or minus myocardial bridge myotomy or CABG. At least severe myocardial bridge defined by CT or intraoperatively should be corrected. And this is the end of the video. Thank you for your attention and waiting for your feedback.